So SafeCare is basically international standards created for resource-restricted settings. So we're all about international standards, local solutions. We were created by 3 organizations: PharmAccess Foundation, based in the Netherlands; Council for Health Service Accreditation, Southern Africa, based in South Africa; and the accreditation body, JCI, which is based in the US. So we are really interested in improving the quality of services provided to everyone. And it's not just the quality of services, we're actually also looking at issues around patient and provider safety. So our standards basically speak to management support, clinical support, and ancillary services. Over time, we found predominantly in our environment, the lowest scoring standard is always risk management. And that has to do with actually infection prevention and control and issues of emergencies. So SafeCare actually provides you a realistic pathway. Basically, most accreditation models really look at you either doing it well or not doing it well. But with SafeCare, we're actually recognizing improvements, and that's why we say level 1, level 2, level 3, level 4, level 5. So it kind of encourages the provider to continue on the quality improvement journey. But we have so many stories from the field, stories that really are disheartening. So when we go out and we do assessments or we do mentoring support to some of these facilities, I've just chosen 3 stories to share. But like I said before, we have so many more disheartening tales. And as we progress in this session, you would understand the rationale for our choice of looking at issues around regulation as a critical step for us as a nation to improve quality and improve outcomes. So the first story, in Facility Y, mortality rate in the neonatal ICU was as high as 100%. But we were actually informed that in the last 3 months, the neonatal ICU had dropped the mortality rate had dropped to 75%. But when we probed further, what we found was a selective acceptance of patients, of neonates. So meaning the neonates that had the least survival chance were turned back. Facility X is actually a general hospital. We found that they had only 1 delivery pack. And so when you have multiple women delivering in that facility, the delivery pack never gets autoclaved. Rather, it gets soaked in bleach between patients. So my question is, how are they preventing infections in that hospital? But the last one hit me because this was something we did recently. A 5-year-old child was rushed to a facility, and this child required urgent transfusion. His PCV was very low, says the lab technician, who we've later found to actually be a cleaner, who was mentored by the lab technologists. And so the mother of the child was said not to be a suitable donor for the child, and the father, of course, was away. So what we heard later were shouts of joy. We found a match. And it turned out that the insurance enrollment officer was a match. I was willing to donate blood. So bring her in, says the cleaner / lab technician. And before we leave, we inquire about the child. Oh, he's doing well. We're able to transfuse him, we're told. Great. Did you screen the blood before transfusing? We ask. The room goes dead silent. So these are the things happening in the field. We have many more stories to share. I think one story that also resonated with me was we went for an assessment in a remote area, and a woman fitted throughout that assessment. The closest referral center to that facility was 5 hours away. And the only reason why she fitted was they did not even have magnesium sulfate. So there are issues in the field, and these issues are really disheartening. Thank you very much.